and Professor Sabagdi. It's such a privilege and honor to be invited here today to share some of my experience of setting up a primary care developmental pilot in Kerala in India, and to reflect with you perhaps on what the interest and relevance to Kerala, to Egypt might be of this particular experiment. But before I get on to that, just a little bit of background and context. How did I, a professor of public health, end up being invited to set up a primary care pilot? I was head of public health workforce for England at a time when there was a request from Government of India for my loan to help them set up the first Institute of Public Health in India. So I went to India for the first time to work there intensively with Indian government. And I became more and more involved with some discussions about health priorities at the top level, and discovered that their biggest gap in terms of healthcare was primary care. And as a consequence, was invited by Government of India, Wellcome Trust, and DFID, the UK Department for International Development, to write a white paper entitled Strengthening Primary Healthcare Partnerships, Opportunities for Partnership, Strengthening Primary Healthcare in India, Opportunities for Partnership between the UK and India. Now, I point this to you because it was published in full in the BMJ in 2012, and it might be of interest to some of you because I know that it generated a lot of interest globally, particularly from developing economies in Latin America, where there was a sense that it could have been UK Chile or UK Colombia, since the issues are common to so many countries. And that led to two final projects. One was to lead the evaluation of India's biggest health financing scheme, again, which pointed out that if you want value for money, you need primary care. If you put all your money into providing free hospital care, you're not going to get an accessible, affordable healthcare system. And that's what led to Kerala then saying, well, can you help us develop this pilot? So exactly what did we do? We co-developed. This was not about us going in and saying, well, step aside, we know how to solve your problems, but this was about co-developing and co-producing the first comprehensive primary care pilot in India, drawing on UK best practice. We did it in Trivandrum, the capital of the state of Kerala. You can see the populations covered by the 3 primary health centers they gave us. They were located in 3 different corners of Kerala. You can see one up there, one in the middle, and one down there, which made the logistics of training rather interesting. The NHS team was pretty modest. It was 4 family physicians, a psychiatrist, and me. Some had massive experience of doing primary care training in India. 2 spoke Malayalam, and they were of Kerala origin, which I think is extremely important to establish immediate rapport and friendship with local stakeholders. Why do I think the Kerala pilot may be of interest and relevance to Egypt? In preparing for today, I was looking up the burden of disease and health economic indicators. These are taken from the World Bank Comparative Global Statistics, so I apologize for the fact that some of them are rather old, and I'm not going to read them all out to you, but I was struck by the similarity between the life expectancy. You can see it's about, in fact, the former Minister for Health said it was 71, and this particular one says 70.9. India is about 68. Egypt, thankfully, is doing very well with communicable disease mortality, whereas India is doing far less well with that. But then Egypt seems to have overtaken India with its non-communicable disease burden. Look at the diabetes prevalence. Look at also the proportion of women receiving at least 4 antenatal visits. Now again, it was mentioned this morning that there was a wide variation in this. It's certainly far from the ideal of 100%. And look at the out-of-pocket expenditure. We've had a lot of discussion this morning, so I'm not going to labor the point here. Other similarities are that both countries have a clear commitment to progress rapidly towards universal health coverage and recognize that a better primary, secondary, tertiary balance is absolutely vital for an affordable and equitable universal healthcare system. Egypt has an advantage in that it already has an impressive primary healthcare network which is of good quality with well-trained staff. And possibly what is needed here is just a bit of refocusing and reshaping the system and training people to work a little bit differently. The final point I'd make is, there are world-class, incredibly impressive hospital facilities in both countries. So what stands in the way of developing low-tech, inexpensive primary health centers? So that's my question. What did the Kerala pilot actually achieve? These are the findings of an independent DFID funded assessment 1 year on. This was an assessment, it was not a formal evaluation with lots of before and after data collected. We have got some baseline data, and when the after project data are collected, we will have an impact evaluation, but this is just a sort of snapshot from interviews. Look at the greater public confidence that exists now. So here's a patient from one of the PHCs who has said, now I feel it's not less than a super specialty hospital. Now I come here, whether for a general checkup or for any health issue. Here at this facility, there is screening, diagnosis, medicines for fever, cholesterol, and blood pressure. There are better relationships with community leaders. So a medical officer is saying, the local self-government support is very good. In fact, it's some of the main reasons for the success and sustainability of the project. Patients now trust us for treatment. The relationship between the staff and patients has improved. Staff believe that there are improved training and expansion of services. So they're saying we received training on diabetes and foot care and hypertension and mental health and immunization and antenatal care and so on. We're able to provide services more confidently at a lower cost. We provide health education and diet tips to our patients. All of this has increased patients' knowledge about diseases. And finally, improved infrastructure. There are lots of improvements in the buildings. There's an office building. Some of this was not part of the original project, but it seems to have snowballed and created so much energy and enthusiasm that there are infrastructure improvements going on since the project, the actual formal project ended. Most of the day-to-day operations have been digitized. Registration and pre-check activities have started. There's enhanced training for all staff on different topics. What did it cost us? The rapid capacity building just took 6 months. That's all that the government gave us. A word of caution here, I think embedding the service into the wider healthcare architecture would possibly take another further 6 months, depending on system receptiveness, or a little longer. We insisted that the pilots would focus on existing staff only, because my point was, let's try and get the staff to do more things, and then if we ask for more staff, additional staff only if necessary. So the costs were modest. They included upgrading the infrastructure, training and continuous supply of medicines, and reimbursement of the costs of the NHS expert team that went out. And they were modest enough that the Indian government met them, but there were several global funders who were interested in funding the project, because primary care is a global priority and they're aware of it. So what framework did we use? I know that there is going to be a discussion later about, is this family medicine or is it general practice or primary care, what is it? But frankly, we could have, in India, that kind of debate can go on for years. So we were not prepared to enter into many discussions. What we persuaded them to do was to adopt Barbara Starfield, the late Professor Barbara Starfield's principles of primary care, which are, in fact, they were highlighted by Professor Baker. She mentioned it in the context of the UK NHS. But Barbara Starfield said it should be a friendly, competent, trustworthy first point of contact, whole person focus. So if somebody is pregnant and diabetic and has a sprained ankle, all of that can be looked after in one place. Longitudinality, so if I have diabetes, I can be looked after for all of my life in the primary health center. Coordination of care if I need care from 2 or 3 different services. Gatekeeping, we talked about that. And the WHO has added this bit, which is very important, addressing the wider determinants of health. And there are incontrovertible proven benefits of such a primary care system. I mean, the literature, there's a mountain of evidence for this. And they go on from better health outcomes at lower costs and lower infant mortality all the way to healthier populations and greater cost effectiveness. And in fact, even within countries, what has been found is that if one region, for example, if Aswan did it and another region didn't, then the variations between the regions would become very evident very quickly. So what exactly did we do? We co-designed new ways of working, building on good and excellent practice. So we said, why don't we give the buildings a lick of paint and make them the pride of the community? I don't know that I would have chosen this particular color myself, but it did make for a very bright building. You know, the PHCs look bright, and people like coming to them. We said, let's have a fruit and vegetable garden. One of them already did, and we encouraged the others to do the same, and they distribute the fruit and vegetable to the poor. We said, let's improve the sitting area, so now there's safe water drinking for patients who come in. There's a TV monitor which currently shows soaps, but the idea was that you could have health promotion strap lines in due course. And we said hand washing facilities everywhere where there's patient contact. We insisted on multidisciplinary, mainly work-based training. So everybody learned together, and it was work-based training, so it didn't take anyone out of their clinic time. And you can see that the training is carrying on in the porch of the PHCs, and the person who's training them is the vascular surgeon from the local medical school. So we said, in order to develop care pathways, why don't you, the academic forum of the local medical college, pick 6 topics for us? So we created, because there was not a department, an academic department of primary care, we said to the heads of departments of diabetology, orthopedics, psychiatry, general medicine, obs and gynae, and so on, why don't you form an academic forum and choose some topics? And these are the topics. They said, why don't we work on them? 2 MDG topics, antenatal care and childhood immunizations, 2 non-communicable diseases, hypertension and diabetes. And because there's a very important diagnosis, treatment, care and referral function in primary health centers, they said, let's do management of fever. And the very neglected area of mental health, they said, let's do depression. We developed new protocols and updated existing ones. So where there were national guidelines, we didn't interfere with them. We said, let's see if you implement them well. So for example, the Indian diabetes guideline stops with, if someone has diabetes, treat them in this way. But there were no complication screening protocols, and we wrote those because foot care, renal checks, these things can be done in the PHC. Why do people have to go to Aswan Heart Center or somewhere to get that sort of thing done? We established teaching by secondary care clinicians in the local health economy and allied health professionals. So the podiatrist, even the cobbler from the local village, who knew a lot about foot care because he had been designing protected footwear for diabetic patients in the community for years, but nobody had ever asked him whether he knew about diabetes. So we called him in and said, look, we want some friendships established in this place, and there were. We promoted the PHC lab for diagnostic tests. We encouraged formal referral systems. So the vascular surgeon said, you treat them to this threshold. If there's a problem, then refer to me. And I will come every 2 months and discuss cases with you. And we ensured these friendships developed. So there was a lot of task shifting within the team, sharing and relationship building. We implemented an IT system. It was a very basic computer-based record, and established a registration system, which you can see at the bottom. So what now happens is if someone comes and registers, if they're over the age of 30 and they're not horribly ill, they go to the nurse. So the nurse takes a height and weight. She does a blood pressure. She takes a finger prick test for blood sugar, and she measures waist circumference. And the computer works out a BMI. She says, go wait for the doctor. So the doctor may say to you, well, you have a cough and cold, and that will recover. Here's a prescription for paracetamol. But by the way, I don't like the sugar. I think you better come back, and we better follow up on that. So they are now beginning to identify many more silent diabetics and silent hypertensives in their community. And now the computer system is allowing them to do simple audits, which they're discussing in their business meetings, making it all more interesting. And it was intended to support the introduction of performance indicators and monitoring at other levels in due course. We ensured a continuous supply of medicines, and discourage medicines of uncertain benefits. So no injection paracetamol anymore, we said. Please, no more of that. There's no need to inject paracetamol. They were giving 200 injectable paracetamols a day. So we said the time that's freed up, you spend on foot care checks. But that isn't easy, and I'll come on to that in a minute. But I think the most rewarding was developing the community leaders. They call them local self-government institutions in Kerala. So these are community leaders, the village leaders, as the bridge between the public and the PHC. So we said to them, please be the PHC ambassador. Encourage the local population to come and use the PHC. We said, be the community champions. So share the community's problems with the PHC so that they can help address them. And be public health leaders. Please promote health in the community. We need you to go out there and say, quit smoking, ask the local tobacconists not to sell to children, sell cigarettes to children, talk about alcohol and domestic violence, and sanitation and safe water and vector control. And by the way, why don't you, the community leaders, stand up and say, I'm not asking for injections anymore. And so you can do the same. Or for every cough and cold, you don't need an antibiotic. So listen to the doctor and trust them if they think they want to try you without an antibiotic for the first couple of days at the very least. And they relished the idea. So you can see at the bottom, the doctor on the left has his arm around the community leaders. So the friendships were extremely important. What worked at the end of this interim phase? Closer links and friendships, most definitely, between several tiers of clinicians. The work-based and multidisciplinary learning was hugely welcomed. Primary care people became important. They felt valued. They discovered they could do hugely more, understood how to become team problem solvers, and review their own work through these audits. And the local self-governments absolutely relished their role in primary care delivery. How were the pilots different? What did they teach the UK? The PHCs have now become guardians of the health of their community. In the past, they'd have sat there and waited for sick people to come through the door. Now there are pop-ups on the computer. You get a reminder to say, next week so-and-so is due for an antenatal check, or this child is due for an immunization, or this person's due for a diabetes check. And so they have become proactive guardians of their community. They have team-based individual roles, but the whole thing makes up a team sort of collaboration. They are writing their own protocols now for asthma, for how to deal with chest pain and all sorts of things. It's exposed the need that you need continuity of this kind of effort to ensure that it's truly embedded in the system. And the UK certainly learned from it the benefits of engaging community leaders in primary care. In fact, the picture at the bottom is our previous public health minister, Anna Soubry, visiting the project, where she stood and said to the community leaders, I'm very humbled to see the interest you're taking in primary care, and we need to do something more about that back in our own country. The DFID funded assessment too threw up some challenges. That staff turnover undermines continuity. You need to keep them together for maybe a year or two so that it really gels and it becomes effective. There's the need for ongoing monitoring and support. There are practical things like lack of internet connectivity can then make the effectiveness of IT limited. But then we said, why don't we use solar energy? And they were thinking about solar-powered computers for the future. IT wasn't being consistently used, so the population data registration was a bit slower than intended. And there are no incentives as yet for complying with new ways of working in the future. So there is a phase 2 about to begin, and I think these are the sorts of things one could do in phase 2, a formal impact evaluation, establish an academic department of primary care in the local medical college, train the first master trainers. Here are all the staff of one of the PHCs. They were super, and I think they could be made into master trainers who can then extend the project to other parts of the state and the country, expand guidelines to other conditions, establish continuing professional development, and establish all those other things like performance-based incentives, and very importantly, how to enhance primary care staff recognition and status. And finally, in conclusion, the DFID-funded assessment concluded that the duration of phase 1 was too short to change the overall ecosystem. Nevertheless, it has made the policy makers and field workers realize the potential of primary care institutions to achieve UHC in Kerala, and it concluded that the pilot has provided a road ahead for others to follow. And I really do believe, having read about Egypt and its impressive primary health care delivery systems that you already have, that it would take very little more effort actually to translate this kind of learning and adapt it into a comprehensive, sustainable primary healthcare based delivery system. So I'll stop there and thank you for listening.